When conducting a pain psychology assessment, it is useful to break down the process into distinct stages. Considering the assessment process in stages is useful because each identifiable stage of a pain psychology assessment involves somewhat different goals and methods in order to maximize its value. This video will provide a description and practical recommendations for conducting pain psychology assessments in terms of 4 separate stages of the process. The first stage of the pain psychology assessment contains the initial referral and chart review. Upon receiving the initial pain psychology consult or referral, the immediate goal is to determine whether the referral is sufficiently clear regarding the nature of the request, or whether it first instead requires clarification with the provider. It is important, for example, to clarify whether the request is for an assessment question, such as concerns about opioid dependence or implantable device candidacy, or instead for a treatment request by pain psychology. A pain psychologist should have a definitive referral goal in mind before they try to contact the patient, because this will allow them to communicate a clear rationale to the patient regarding the visit and improve the patient's likelihood of participating. This contrasts with the common circumstance where the pain psychologist has only a vague referral question in mind when contacting the patient. This latter circumstance is more likely to create confusion or resistance in the patient about the referral and less motivation for them to participate. I also recommend performing a brief chart review before contacting the patient about the pain psychology assessment visit. Patients with chronic pain often struggle with related medical and mental health conditions, as well as with difficult psychosocial circumstances such as unemployment and financial stress. Having an understanding of the patient's health status and psychosocial circumstances can be of great benefit to the pain psychologist when first reaching out to the patient, because it allows them to convey a better appreciation of the role that chronic pain may be playing in the patient's overall quality of life, and better tailor their description regarding how pain psychology may benefit the patient based on their individual circumstances. After contacting the patient and setting up the initial appointment, it is useful to consider the pain psychology assessment as formally beginning when meeting the patient in the waiting room, not when sitting with the patient in the office. The pain psychology visit begins in the waiting room because there is a host of valuable information to gather in that initial encounter, with much of this information particularly valuable for the purposes of a pain psychology visit. If the pain psychologist does not view the waiting room introduction as part of the visit, they are instead likely to overlook meaningful clues regarding the patient's level of functioning. Neuropsychologists have recognized the importance of collecting initial data about their patient's cognitive status from the waiting room encounter for decades, and pain psychologists can benefit from the same wisdom. For example, how was the patient dressed for the visit, and what is the quality of their hygiene and physical appearance? The information that the psychologist can visually obtain regarding these questions offers insights into the patient's level of independence, their social support, and their mental health. Secondly, is the patient ambulatory, or instead requiring the assistance of a cane, walker, or wheelchair? The observation of how a patient ambulates from the waiting room to the office offers valuable objective data about the functional capacity of the patient, as well as valuable subjective data about the patient's perceived level of disability. Thirdly, what pain behaviors are noted in the patient's movements? Patients will often communicate as much about their pain symptoms non-verbally as they do verbally, and this information will largely be missed if attended to by the psychologist only when the patient is sitting in the office. Noting the strength of their handshake, the pace of their ambulation, their need for breaks or rest, and many other nonverbal cues about the experience of their pain are all important sources of data for the pain psychologist to note on the way to the office. The value of such information is also why it can be of value to intentionally meet with the patient for the first time in a neutral waiting area, rather than, for example, having them show up directly at the pain psychologist's door, in order to provide an opportunity to observe this behavioral information. The third stage of the pain psychology assessment consists of the clinical interview. The clinical interview stage of the assessment process may already seem familiar to most pain psychologists. However, even in this stage, there are strategies infrequently employed by pain psychologists that can augment the value of the clinical interview. For example, questionnaire administration is a routine part of pain psychology assessments, and these measures can offer important information about different types of pain and mental health symptoms. However, patients with chronic pain frequently struggle when completing questionnaires, such as requiring additional time or needing accommodations, and these behaviors may be clues about their level of independence, their degree of interference related to their pain, their cognitive status, or even impairment possibly created by prescription pain medicines. Once again, this information is easily missed if not formalized into the pain psychologist assessment plan. Consistent with this philosophy, during the face-to-face portion of the clinical interview, the pain psychologist can benefit from specifically attending to signs in the patient of oversedation, their pain behaviors, the patient's sitting and standing tolerance, and their accuracy as a historian. These and related behaviors during the interview process can further supplement the verbal and questionnaire data obtained in meaningful ways. The final stage of the pain psychology assessment is the process of writing the report. Even though pain psychologists are generally highly experienced report writers, there are additional strategies for this stage that I recommend in order to maximize the value of the assessment report for the patient and for the referring provider. One strategy that may seem counterintuitive is to begin the pain psychology report at the bottom rather than at the top. Unlike more general psychology reports that are often written in a way as to be understood by other psychologists, pain psychology reports are most likely to be read by referring physicians. When a physician reads a pain psychology report, they are likely to devote most of their attention to the bottom of the note, gathering the primary conclusions, the diagnoses, and the action plan recommended by the pain psychologist. It therefore makes sense for the psychologist to begin their report by focusing on the section that is of most value to the referring physician, rather than completing this vital section at the end of the report writing process when the psychologist is more likely to be rushed or fatigued. Secondly, ensure that the conceptualization and recommendations of the report address the specific referral question. This strategy works especially well when accompanied by the earlier discussed strategy of first clarifying the referring question with the provider. One of the worst-case outcomes for a pain psychology assessment is to have the patient and psychologist commit the time and effort to the visit and the report writing process, only to have it fail to properly address the referring physician's primary concerns. Thirdly, if your recommendations include requests for actions by the referring physician or other providers, relay these requests in separate addendums to the primary note in the electronic medical record, rather than in the main report body. The full assessment report by a pain psychologist is often long and detailed. Medical providers will rarely be inclined to review these reports in detail, making it easy for them to miss the pain psychologist's request for follow-up action unless these requests are made easy to recognize. Although there are multiple ways to help such requests stand out, one of the clearest and easiest is to create a short addendum to the main body report containing only the specific action request that then requires the provider's co-signature. Such an approach makes it as simple as possible for the referring provider to recognize and respond to the results of the pain psychology assessment.